So good evening, everyone, and welcome to the Head of the Schuylkill Regatta's 50-year, 50 Stories Story Hour. My name is Jennifer Wesson. I'm the Executive Director of the Head of the Schuylkill Regatta. On behalf of the Board of Directors and the Committee 50, we welcome you to our 12th Story Hour. We are excited to have you here and to welcome a fabulous group of panelists this evening. It is going to be a fun chat on how to keep ourselves healthy and what to do when we're not feeling so healthy. I'm going to start by just giving a few housekeeping items. I am recording this session so folks can pass this along afterwards and view it if they were not able to be here. I have everyone on mute right now, so if you want to contribute, you'll just have to unmute yourself. But we do just ask you to be really, really cautious. There's not a lot of background noise and everybody can hear. We will leave the chat room open. So at any point in time, you want to write something in the chat room, a question, or add on to an experience, please do so. We will get that. We'll get those questions out to our panelists as we go along. And then at about 7:45, the last 15 minutes or so, we'll open up the floor and folks can chime in and tell stories or ask questions of our panelists live. So without any further ado, I know everyone here is pretty much a repeat story hour attendee. So you know the format. I'm going to introduce our first panelist, and she will introduce the remainder of our panelists tonight. They'll give some really great information, and then you'll have opportunities to add to that. This has really been just such a great experience having these story hours with each of you. It's really been a great opportunity to connect the community and talk about some of our favorite subjects. So without any further ado, I'd like to introduce Dr. Naomi Brown. She is a pediatric sports medicine physician who specializes in the overall care of the young athlete. Dr. Brown grew up outside of Philadelphia in Lower Merion and completed her undergraduate and medical studies at Tufts University in Boston, Massachusetts. She then returned back to her hometown of Philadelphia for her residency in pediatrics at the Children's Hospital of Philadelphia. After working for 3 years at Nemours Alfred I. DuPont Hospital for Children in the emergency department, she completed her fellowship in sports medicine at Boston Children's Hospital and subsequently returned to CHOP after her fellowship. Dr. Brown's interests include overuse injuries and prevention in the young athlete, bone stress injuries, dance medicine, hypermobility in the athlete, and the use of ultrasound in the office. She is active in orthopedic and sports medicine research and has written and presented numerous papers about her research. Dr. Brown is an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She and her husband, Brendan, are very active with their 2 elementary age children, Matthew and Nathan. You can find her running along the Schuylkill or at Edgeley cheering on her young soccer athletes. And as an addendum to that, I'd like Dottie Brown to jump in and say a few words about Naomi.
Since I'm her mom, Naomi may not have realized this until, frankly, she was doing her emergency medicine training, but her parents knew early on that she was going to do something in sports. She had 9 varsity letters in high school, and then she went off to Tufts and was on the ski team where, unfortunately, she tore her ACL, but that gave her a firsthand experience on what it's like to have a sports injury. And when she was in the emergency room doing that training, she realized that what she really loved were the sports injuries. So we all knew she was going to end up there. And Naomi, take it away.
Thanks, Mom. I have to say this is a rarity that my entire immediate family is on this, and it's a little bit overwhelming to me. I usually do not have them at all on here. I see my dad and my sister. So anyway, thanks guys and everyone for being here. So as Jen very nicely mentioned, I am pediatric trained, although my fellowship was also in adult. So I've taken care of a lot of rowers in my career, I know I don't focus primarily on the adults, which most of you, I think all of you are, obviously, but I'm going to give an overview just about the common rowing injuries that you might see. So I'm just going to share my slides for a minute. And can everyone see that okay? Yeah, okay, perfect. So just need to highlight, this is my mom and my cousin Katie rowing at the head of the Schuylkill a couple of years ago in the Masters rowing. So I blame my mother for not getting into rowing, and actually I blame Ellen for that because she didn't introduce my mother until my mom was in her 50s. So I was not a rower in high school. I wish I were, and I have taken rowing lessons and I do love to row. I just wish that I had started that much younger. But benefits of rowing, speaking of starting at any age, it's an amazing sport, as we all know. It's low impact exercise and you have lots of high results from it. And it's a full body workout, so it's excellent for everyone to do. It reduces stress. You're on the river, you're outside, you have these psychological benefits of being outdoors, and you can row at any age and start at any age, which is one of the rare sports. There are a lot of sports out there that you really cannot pick up in your 50s or 60s, but rowing is one of them. I actually just got a message from one of my partners who just joined one of the boat houses, and he's up in Vermont right now doing a week-long course, learning more technique on rowing, and he's in his 40s. So it's great that we have this ability and we have this sport, and it's right in our backyard. And obviously, everyone knows my mother's book and her introduction. I just got a message from one of my partners who's going to American Medical Society for Sports Medicine. She is going to be a visiting lecturer over there, and she asked my mom to bring some of her books over to Australia and New Zealand. So the books will be crossing the Atlantic and all the way on the other side of the world to be introduced to the sports medicine physicians in Australia and New Zealand. So rib injuries are one of the most common injuries that you'll see, specific to rowers, and a lot of that's due to rib rotation and diaphragm spasms. You can have a bone stress injury to the rib. You can have this because of poor mechanics, and a lot of rowers will just continue to push through the pain, just say, it's there, it's fine, and they don't realize that the more you push, the more injury you might cause. Some things that might be helpful are some diaphragm breathing exercises or gentle rib mobilizations, and we'll touch base on this in a little bit when Chris Fayak will talk a little about that as well. So upper extremity injuries, really common. You can have tenosynovitis in the fingers, especially due to gripping the oar and stressing the longest fingers. Sometimes this can be alleviated with using a lifting strap while erging. You can have extensor tenosynovitis of the wrist. Sometimes this can be helped by keeping your hands warm during activity. Forearm compartment syndrome, either acute or chronic, can be seen, and this is often related to the death grip. You're holding onto the oar too tightly. Epicondylitis at the elbow. This is either medial or lateral, commonly known as tennis elbow or golfer's elbow. And you can get shoulder impingement, often due to overgripping from feathering, either sweep and skull. It can be an acute injury, mechanical, or repetitive overload. From lower extremity injuries, lots of different things that you can have. You can have hip flexor tendinopathy due to overuse and lack of hip extension with rowing motion. Sorry. We can have femoral acetabular impingement about the hip. That typically is not an injury, but it might come about as having hip pain. It's kind of deep anterior hip pain. You can have patellofemoral pain from overcompression at the catch. Need to be more perpendicular to the erg or the water instead. We can have IT band syndrome at the lateral knee. Excessive knee bending can cause irritation or friction as the IT band rubs against the outside of the knee. You can also have IT band syndrome up at the hip as well, as my mother can attest to, and that can be really frustrating and annoying. And you can see on this picture here, the IT band runs from the lateral hip all the way down to the lateral knee. We can have shin splints or medial tibial stress syndrome, as it's medically known as, which is often due to pulling up the slide towards the catch with the feet on the erg straps or the boat shoes, depending on what you're doing, instead of engaging their hamstrings. At the spine, you can have lots of different areas where you can have pain. You can have thoracic or your mid-back or low back pain. This can be due to postural kyphosis and excessive tilt at the pelvis. So what I mean by that is that your pelvis, if it's tilted in the wrong position, you'll overengage some of the muscles and that can deactivate the core muscles and overengage the hip flexor, the psoas, and that can cause a lot of back pain. Lumbar disc disease, you can have disc herniation or facet irritation, a lot of different kind of lumping it together as lumbar disc disease, and that's often due to some poor flexibility in the hamstrings, weakness in the core, poor core stabilization. SI dysfunction, your sacroiliac joints are the dimples in your low back, and you can have a lot of back pain, especially when you're rowing at those areas, and that's often due to poor pelvic activation and positioning. You can have spasms of your muscles about your hip, your lateral hip, and your posterior hip. Those are the glute medius, piriformis, quadratus lumborum muscles, and that will strain the sacroiliac joint and the sacrum. So one of the risk factors that's talked about for low back pain is often transitioning from sweep rowing to erging. And so erging is the best you have when you can't be on the river, but it's not exactly the same. And so sometimes you can have a lot of injuries due to erging. And often these are seen in the sweep rowers because you have asymmetrical development and suddenly they're going into the symmetrical exertion on the erg, and they can have a lot of injury and pain. So I just want to introduce our speakers. We have Dr. Chris Fayak, who is at Penn Sports Medicine. And we have, sorry, I'm just going to bring up my little information on them. Dr. Fayak is a primary care sports medicine physician at Penn Medicine with the departments of family medicine and community health and orthopedics. He is the chief medical physician for Penn Athletics and is the program director for the primary care sports medicine fellowship. He has been a team physician for Penn Athletics for 6 years, as well as he was at the University of Delaware for 4 years prior to joining Penn. In his role as a team physician, he has cared for male and female rowers competing at the NCAA level, as well as rowers competing at the international level. Dr. Fayak completed his medical school, family medicine residency, and primary care sports medicine fellowship, all at Thomas Jefferson University. Dr. Keith Robinson has been a practicing physician since 1987 and on Penn Medicine faculty since 1989 in the Department of Physical Medicine and Rehabilitation. He is currently the chief of rehab at the Corporal Michael J. Crescent Veterans Affairs Medicine Center in Philadelphia. He has over 40 years of rowing history and current rowing home base is the Undine Barge Club of Philadelphia. Merrill Hilf received her Bachelor's of Science in Physical Therapy from Thomas Jefferson University and her doctorate from Arcadia University. She has been a practicing physical therapist for 32 years in various settings that include acute care, acute rehab, outpatient home care, and adjunct instructor. She is currently a full-time generalist for Keystone Care, and she's been a master's rower since 1985. So on that, I thought that we could first talk about rib injuries. I feel like these are the most frustrating to rowers and the most unique to rowers. So Chris, do you want to give a little spiel on rib injuries?
Sure. And so a little more background. So I am not a rower, no family members as rowers, not really many friends as rowers. And so I've really learned a lot about rowers from my patients over the last 10 years being at University of Delaware and University of Pennsylvania. And, you know, one of the fun things I like with taking care of all athletes and, you know, Penn, I think we have 33, 34 sports. And I played football when I was in college, basketball, baseball, track, soccer. You know, sometimes there's stereotypes of different personalities depending on sports. And, you know, I think rowers have their own personalities and approaches. And so it's one of the things I try to learn when taking care of patients of, you know, how can I match personalities, expectations, and kind of just overall with a lot of them. So the rowers have interested me a lot. And I always tell my my student athletes of, I love getting to know them, but it's not a good thing when they get to know me pretty well, because that means they're having a lot of injuries and seeing me a little too often. And we've tried also kind of preventing injuries. And so rib injuries kind of really interest me of when seeing them and, you know, looking at injury patterns, and there's a lot of risk factors and things that go into them. And so that's one of the reasons when Naomi had asked to talk about them is it's probably what I see in the office the most. And if anyone's had a rib injury, they can be really frustrating. And so I think some of the simple things of just starting with the history, you know, Naomi touched on is pain in the ribs. You know, this is one where there's not really too much of a history you have to go into or too many physical exams. But I think some of the other things we look for are, do you have pain getting in and out of bed, getting in and out of the chair? Do you have pain with coughing, sneezing? Do you feel any clicking or popping? When you start having some more of those other symptoms, I worry more about, are we dealing more than a strain, or are we starting to, deal with like a stress reaction, a stress fracture? Or unfortunately, I've had a few athletes that have had full fractures of their ribs, and hate to see those because they're so painful and debilitating for a long time. In the exam, I think other joints like the knee, the shoulder, there's a lot of specific maneuvers we might do for them. For the ribs, it's really, where does it hurt? In the ribs, as Naomi had the one diagram up, where some of the muscles overlap. Ribs 5, 6, 7, and 8 are the common locations, more in kind of the front of the chest that we'll see them. And that's, just palpating, pressing on the chest. Does it hurt? Sometimes we'll squeeze on the side of the ribs and see if we can recreate the pain. And then from there, what do we do with it? And so sometimes simply is more just rest. Now, if I tell all my patients or athletes to rest and see me in a couple of weeks, I don't think I'll have that many people come up and see me. And so this is the fun part where I like to always is, it's like kind of nitpicking details of like, all right, what can you do today? What can you do tomorrow? And how can we advance? I've learned a lot from my athletic trainers, physical therapists, and coaches of, the demands of the athletes. And if maybe they can't row, but what else can they do? And so I think how I try to think about it is, is it mild, moderate, severe? The moderate, severe ones, I might try to get imaging. If anyone's ever had a rib injury, X-rays aren't always the best. They're hard to see. There's, your lungs, your hearts, so many bones overlapping. And so X-rays, unless it's a full fracture, oftentimes for stress reactions and stress fractures, we don't see anything. And so what I'll usually get, depending on, and I think, sometimes it can be a simple question of let's get an MRI to really look into detail of what's going on. And then sometimes we'll use our clinical judgment of where, if it's the off season and there's no rush to get back, we don't have to get any imaging. But a lot of times I'm seeing my athletes in season, and we kind of need to know for coaches, for planning, for the boat preparation of who's going to be on the team, of how long are they going to be out. And so there used to be some old guidelines that from like an MRI, you could look to see, is it just a stress reaction, a stress fracture, or full fracture, that they might be out for 2, 4, or 6 weeks. And that's not perfect for a timeline, but it's something where I think, athletes like to have something objective other than, hey, we'll see you every week and we'll see what happens. And so that's one reason why sometimes we will get some testing so we can have some better answers and preparation and planning for the team. And so depending on the level of severity, that can also help of, is it okay to kind of push through some of these symptoms? Or if there's a stress fracture or obviously a full fracture, I'm not going to let them go out and compete. Some of them will be like, oh, it's only a rib. What's it going to do? Well, if anyone's ever had a rib fracture, they're sharp. You have a lot of important organs that they're protecting. And, luckily I've never seen it, but we worry about it. If you have a fracture, could it pierce the lungs? Could it pierce the heart, or your spleen, or your liver? And so those are things that, I try not to scare my students or patients when I see them, but sometimes if they're not listening, you have to kind of get drastic and kind of be like, this is what we're looking out for, of reasons why to hold them out. And how I always try to tell our students when I see them for their sports physicals at the end of the year, I'd rather know about something sooner than later. And so I think this is an injury that if we can catch sooner and rest, modify, get them into physical therapy sooner, then a lot of times it's a shorter rest, rather than if they wait until the pain's unbearable, usually then it might be closer to that 4 to 6 week recovery there. And so some things to do. One is, if you have the time to just, stop rowing, you can obviously do that. And that makes my job easy if that's an answer. Cross training, I think Naomi hit it on the head of where I've learned a lot of where rowing in the boat is a lot different than the earned. And so a lot of my students have told me they were a little bit more worried about injuries during COVID when they couldn't get out on the water. Well, they didn't have access to the boat, and the only thing they had was the erg machine, and there was a few more injuries there. Other things of risk factors, I had one that had a wrist injury. He had never had a rib injury ever, was very proud of that. He had always kind of looked after his technique and his training, but had a wrist injury, and that's what he thought kind of led him to an imbalance to lead to the rib injury. When I have a lot of learners with me, as Naomi mentioned, I'm a fellowship director, and I always say 80% of my job in a patient visit is to convince them they need physical therapy. And so in that, how the whole visit, my kind of how I kind of lead and kind of try to convince them is that, I can help with rest. I don't want to give medications to everyone, but technique, muscle balance, getting your core strength, your upper spine muscles, everything back in order is what's going to get people better. And so that's where a lot of times my goal is really trying to talk them into, this is why you need to do therapy. This is why we need to rest. Maybe we can get them on the bike. Usually not many of them, if they have a stress fracture, can run, but a lot of them can tolerate a stationary bike, or they can do some other activities with the athletic trainer in the meantime to at least keep their cardiovascular, their conditioning up while they're resting.
So Chris, that's an excellent overview. And I think it highlights a lot of the issues that we have with rib injuries. There was a question that someone just brought up to me about dislocation of the ribs. I think really slipping rib syndrome is what he was alluding to. Have you ever seen any slipping rib issues with rowers?
A couple times. And so I think it's, I learned a lot about slipping ribs when I was at Christiana, where if anyone's familiar, there's two types of medical training: allopathic, MD, osteopathic, DO. And there's, I think, some conditions, injuries, and this might be a little stereotype generalization, that I think aren't as accepted in the allopathic world. And when I worked at Christiana, I had a lot of partners that were osteopath trained, and that's where I learned a lot about slipping ribs, that it was real. It's hard to diagnose objectively to on a test, on an ultrasound or x-ray, but my partners would treat them with osteopathic manipulative treatment. Physical therapy can be helpful, a lot of manual treatment to the ribs, and I've had good success of kind of once I can get them into the right hands. And my base training was family medicine, and then did the extra training of sports medicine. I think of some of the family medicine things that you'll learn, know your limits and know where to get your patient into the right hands if you can't treat them or get them better as well. And so that's where of kind of recognizing a diagnosis and getting them to where they need to be. I've had good luck with finding an osteopathic doc, which there's not that many. PCOM, Philadelphia College of Osteopathic Medicine, is one of the largest well-known osteopath schools in the country. They do have an OMT clinic that I've referred a lot of patients to and have had good success.
So I've seen a lot of slipping ribs in my practice, but not typically in rowers. So I didn't know, again, if it was just a more adolescent issue that I've been seeing with slipping ribs. But to answer the question from the that I had on the chat, it's happened to him twice, but with kayaking, and the chiropractor did fix it. And he wants to know what you can do to help, if it happens, or to prevent it. I will say, in my experience, really good core strengthening and diaphragmatic breathing can really help with slipping rib syndrome. I've done corticosteroid injections for this, for both diagnostic and potentially therapeutic. But then otherwise, if it keeps happening and it's really frustrating, sometimes you have to see a general surgeon, cardiothoracic surgeon, and they'll remove that piece of cartilage that's slipping. So just to answer that question. But getting on to the prevention, not just for slipping rib, but for rib stress injuries, or for the treatment of the stress injuries. Merrill, do you want to chime in at all about kind of the strengthening physical therapy aspects for both prevention, and then after you have had a rib injury, what you can do for treatment?
Okay. Actually, I've never really treated much in terms of rib injuries. What I would recommend more than anything is do a complete postural analysis Anybody who is familiar or lived with or involved with the sweep rower knows that they're all lopsided. You know, you can walk behind a crew and pick out who's a port and who's the starboard just by their posture. So some coaches have been doing things where, you know, they make everybody switch sides, which I think is great, especially in programs that don't do any kind of sculling. So obviously sculling is much more symmetrical. So that's where I would start, is doing some kind of postural analysis and seeing what's off and what we can fix. Because I think you're right, you know, when you alluded to the thing about how sweep rowers then get on the erg and all of a sudden everything is symmetrical, that does completely make sense to me, that it would set them up for injury.
Yeah, I think
I'll pipe in. I mean, most of the stress fractures, I think, are more typical in the elite athletes who are overtraining. It's usually a combination of overtraining, not listening to your body in terms of fatigue, and having a weak core. So remembering in rowing that the power is generated by the legs, and that it's not that the upper body's not involved, but it should follow. You should be catching in a relatively relaxed position. So some of it simply has to do with bad technique. So it's really a matter of core strengthening and getting some good coaching where you're really not really more relaxed when you're placing the oar, dropping the oar. You know, and I think, and as Chris mentioned, it's hard to convince rowers to rest. Usually they need about 2 weeks rest. Imaging is often useless for stress fractures. It's usually a clinical diagnosis where you're looking for point tenderness on the rib, but usually you can get people up and moving with graduated activity over, usually by 6 weeks. They're not rowing at full capacity. By 8-10 weeks, people are usually back.
Yeah, I would just want to say, because you've mentioned and Chris mentioned about useless imaging, I'm involved with a national society called Pediatric Research in Sports Medicine, and there's a big push to do ultrasound for rib stress injuries. And so there's a multi-center study that's getting up to look at ultrasound as a potential for diagnosing it. Easy, bedside, and would hopefully give answers right away for the rowers. So, so Keith, you were just talking about, you know, kind of the needing for rest and everything with the rib stress injuries, about 2 weeks. What about the low back pain? Do you think that 2 weeks is enough for the low back pain? Or?
Well, you know, I mean, I think the lower back pain is endemic. All rowers have back pain. We all row with it. We all ignore it. We all row through it. You know, I usually simplify it in terms of pain generators. It's usually spinal or pelvically generated. You know, we are in flexion all the time in the boat. So, you know, the positioning predisposes you to disc herniations, but you know, and I know that what you see on imaging, MRI, does not always predict or does not always correspond what you see clinically. My own view of it is that most of the lower back pain that rowers have is really generated from the sacroiliac joints, from the pelvis. And when you think about rowing, you have, and think about muscle balancing, and think about what we call agonist-antagonist relationships. So if the biceps the agonist, the triceps is the antagonist. We as rowers are in hip flexion all the time. And so the hip flexors usually get shortened and weak. And then we're in we're in hip, you know, that's opposed by hip extension. The hip extensors get lengthened and weak, and we know from muscle physiology that muscles are weak, are strongest when they're in the middle of what we call length tension curve. So if your muscles are too short or too long, they're weak. So that causes that's some degree of pelvic instability that usually is seen as SI joint dysfunction. So remembering that the pelvic is a ring, and that the SI joints really should have no mobility. And even if you can, with pelvic instability, they move 1 or 2%, but it can really induce usually non-radiating low back pain. The other dynamic is that when you're looking at how we're moving a boat down the river, where it's primarily generated by our knee extensors or quadriceps mechanism, although we should be trying to damper that with using the knee flexors or the hamstrings, or using the hamstrings actively when we're trying to control the recovery of the slide. But what happens with rowing is that the quads overwhelming the hamstrings. So it's another, and the quads are also yanking, the lateral quad particularly is also yanking on the iliotibial band, which you mentioned, which is becoming shortened, and that's actually even augmenting more the pelvic instability. So at the end of the day, in terms of strengthening prevention, you have to pay more attention to hamstring strengthening, which you can isolate out or you can do as part of squats, whatever. And you really have to concentrate on trying to keep your hip flexors as flexible as possible, as stretched out as possible. But most importantly is the core strength, and really primarily the gluteal strengthening, or the strengthening of the buttocks muscles, which really are and the lower back muscles, which are the main stabilizer of the pelvis.
Yeah, so my fellows get really tired of me, and every patient I make them do a one-legged squat and see how much they drop into what we call valgus, or how much their knee moves, to look at how poor their hip abductors, their gluteal muscles are. And it's shocking. I'm standing there in heels and I'm doing a one-legged squat and maintaining their balance, and I'm embarrassing all the youth athletes. And they're like, really? You can do that? And it's, yeah, you have to work on it, but you can do it, and you help prevent injury. And my mom actually just asked a question about regular routine practice of yoga preventing injury. Do you feel like yoga is something good to help prevent from low back pain or any of the other injuries we might see?
I mean, I think it depends on the style of yoga. I'm thinking most rowers like the aggressive energy flow. And I think some of the risk with, the bottom line is yoga is great. You do strengthen core muscles, particularly the glutes. There are techniques where you can optimize your flexibility or your length of your hip flexors. One of the big problems with yoga is that with some of the positions, you can really overstretch the hamstrings and cause, I think, micro tears of the tendon, and just really leading to, a chronic hamstring pain, particularly felt at where the hamstrings attach at the bottom of the sits bone in the pelvis. But I think it's one way to go, certainly.
Merrill, do you see any low back pain techniques that you can help with treatment for these patients, or anything that you can give to all the people here as advice on how to prevent themselves from having low back pain?
Prevent from having low back pain? I guess die. As we as we age, we all have some sort of, arthritic changes in our spine. That's inevitable. So I'm totally on board with what Keith had to say about everything about the SI joint, and people kind of ignore that part. And the extensor muscles are basically through the muscles in your butt, and I think they get ignored a lot, because, like Keith said, we spend, when you're rowing, you're always in hip flexion, and then those same people then go to a desk job, and then they're in hip flexion all day. So they spend their lives pretty much flexed. So just having some awareness about that. I mean, I tell people literally, I get, during COVID, when everybody was Zooming all the time, like we're all sitting down, it was like, get up, walk around, put yourself on mute, walk across the room, do some extensions, just simple back extension exercises, just get out of that flexed position, because, if you're spending 8 to 10 hours a day in that kind of position, of course, everything, those muscles are going to get short. And you're not working on strengthening the opposing muscles. So I just want to comment about yoga. It's kind of, there's been a yoga craze, right? Everybody, walks around carrying their yoga mats and they go to yoga classes. And it's, again, it really depends on what kind of yoga it is. So, the traditional people I know that practice yoga for the last, 30, 40 years and much more of a meditative relaxation kind of yoga, that's fantastic. Because it really does encourage lengthening and stretching of muscles and being able to really focus in on what's tight. And it's also a very gradual process. So I worry a lot that people get into yoga, as Keith was saying, and it's like now it's a competitive sport, and we have power yoga and hot yoga, and it's kind of you have to be really careful about how you get into that, and you don't just throw yourself into all these postures that maybe you could do when you were 20, but you can. I've known a number of people that have hurt themselves being too aggressive with yoga and not taking their time, really starting at a beginning with and gradually moving into it. It's similar with Pilates. You have to really move into things slowly and gradually, the older you are. So, but again, it comes back to posture. I say this all the time in boats, check your posture. Is your head down? Are you looking down? There's just a simple saying I say this all day long. Your body follows your head. So if you're staring at your feet, chances are your spine is flexed and your neck is forward and flexed. So just doing a simple postural check on yourself in a mirror is a good thing to do.
That's excellent advice. I think we should all do that right now. Do some chin tucks and make sure we're all sitting up tall. I see some people slouching down there, but it's the end of the day. You're allowed. So obviously, as rowers, a lot of people will, say it's not, are you in pain? It's how much pain are you in? So, any of the panelists have advice on when you should be, actually seek out medical care, and what are some of the risk factors of ignoring pain, and what's good advice for saying when you should actually go call and make an appointment with a doctor?
I'll chime in first. For the rib injuries, if it's not getting better, I think in 1 to 2 weeks, or 2 to 4 weeks of rest, modifications, you've worked on your technique with your coach and kind of tried some exercise, I think that's when usually I'll start seeing patients coming in to help figure out of what's going on, why am I not getting better. One of the things that didn't really touch on, but of bone health can be a big issue. And so I see some people that young athletes, older athletes, that if they have poor bone health and it is a bone injury, it is a stress reaction or stress fracture, they can take longer to heal. And so it's not a problem, but just might have longer expectations for healing. And so sometimes we might have them talk with their PCP or one of our other partners that sometimes if we're really struggling with getting better, kind of have a bone health workup as well.
So I trained in Boston under Kate Ackerman, and Kate Ackerman is one of the team physicians for USA Rowing. And she actually just gave a great TED talk that was, someone just shared it with me, on rowing. And one of the things she talked about was, as a collegiate and a US team rower, that females were just, especially the lightweight rowers, would lose their periods, and that's not normal. And this was, years ago, kind of ignored. And so she's really taken on a lot of the female athlete injury prevention and what's called female athlete triad. So, if you have any, younger female athletes that are having repetitive injury, also look into a bone health workup or a full, are they getting enough nutrition? I think it's incredibly important.
Yeah, this was something that might have been 4 years ago at Penn. We had at least 6 to 8 of our female rowers come back after spring break with rib stress fractures. And, and one of the things of, not that I like injuries or I don't want to see my students injuries, but of the wrong way of saying piqued my interest of injury patterns, and of where that's where I really like to talk with our athletic trainers of why did this happen? And this is something in my mind that can be preventable either through technique, rehab, overtraining. I got bits and pieces depending on how much each athlete wanted to share with me that they were having, like 3-a-days. There were some body image issues, some mental health concerns, and people, they weren't eating well. And so it kind of just there were so many different factors that led into this that, of at what point do we, have like an intervention, talk with coach and really get into that. And that it kind of led us before it was the season before COVID started that we looked to with each team of the top injuries of which ones could we try to prevent. And we talked with our strength and conditioning coaches, physical therapists, athletic trainers to try to give all the rowers kind of homework exercises to work on before the season. And COVID happened. And so we never actually got to follow up with it and see if it, made a difference. But this was something that kind of was really in my mind of hoping could be preventable.
It gets onto what Rick just asked, is any difference between incidents of injuries for sweep versus sculling? So I don't know if anyone wants to take that question of kind of higher risk factors, risk injuries with sweep versus sculling. I know Merrill touched base about, seeing lopsided people.
Well, I've shared a locker room with Merrill. I know she has opinions about that.
Yes, true. So yeah, I mean, obviously with sweep, you add a rotary component that you don't have with sculling. And, it took me a really long time to get over that with sweep rowing, because it was just the asymmetry of it is kind of counter to everything you think you want to do with your body. So, like I said, I've talked to some sweep rowers and stuff, and I do think that some of the higher level coaches are really making an effort to have the students per se, or the elite rowers, switch sides. I think the days of saying like, I'm just a port, that's it. Or I would hope at this point that that's kind of passé, so that, because it really does balance you out if you row on both sides. So I have heard that more coaches are doing that. I think some of the students and some of the athletes don't want to do that because you have a better side usually. But it is good for them, especially the programs that don't use sculling at all. And I also think, now more and more of the college programs are sculling for similar reasons.
I don't know the specific incidents, but I will say anecdotally, I will see in the sweep rowers, they'll have more potential like one-sided SI pain or shoulder injuries. I've seen labral tears. I've seen one concussion rowing. The oar hit the bridge and it came back and hit him in the head. Not a common injury for concussions, is very low risk with rowers. But, I think that I'm sure there's data out there. I just don't know all the incidents. And so Kristopher just asked a very good question. If you're the head coach of a Philly high school program and very limited time to incorporate stretches and strengthening prior to and after practice, what do you think are the 3 to 4 most important exercises or stretches that should be done immediately before and after practice on the water? It's a great question.
One thought, just thinking about the yoga, is doing a cobra where you're in the prone position. You're using your upper body to extend your hips, so you're stretching out your hip flexors. And as you're doing that, you're contracting your your rear end muscles, your glutes.
Yeah, that's great. I mean, I would say, just to chime in here, is dynamic warm-ups are the most important things before you get on the river. So those are activating your muscles, warming up your muscles before you get in the boat. So doing things like open the gates, butt kicks, knee highs, things like that, doing some really good warm-ups that take a couple of minutes to do to activate the lower body and the core. Maybe doing some shoulder circles as well, getting the shoulders moving. And then afterwards, after you get off the river, spending 5 to 10 minutes of doing static stretches. So you want to stretch when your body is warm. So if you do static stretches before you get on the river, then you're going to really be hurting your muscles more. So that would be my 2 cents on that. I don't know if anyone else wants to chime in. So one of the things I did not mention in my slides, but there's a question in the chat about foot pain, especially someone who has very high arches, tight tendons, and their extensors on their foot and poor dorsiflexion. So it sounds like very tight heel cords is what he's describing and causing some metatarsalgia. Any advice for someone who is having a bad flare after returning to rowing of what they can do for their foot pain?
I might want to look at the angle of the foot stretchers to see what you know, if in the club boat or their own boat, that may be encouraging tight Achilles tendon that could lead, you know, go on to plantar fasciitis and or flexor tendinopathy of the feet, metatarsalgia. So.
If I had a runner with metatarsalgia, I'll probably, you know, recommend potentially some orthotics or something in the shoes. Can you put that in the boat? Have you ever had anyone where you can put something in the boat shoes?
I mean, you can. I mean, I think when I've used orthotics, usually people have back pain and you realize they have a leg length discrepancy, and that's usually more than 1/4 of an inch, and sometimes just putting a small lift in the shortened side in the shoe helps. Or you usually do it in the shoes they're wearing every day. And usually it can be an internal lift if it's not a big discrepancy.
Yeah. And Jerry, I would just say, if you haven't seen a physical therapist, then I would probably very strongly recommend you seeing one. Merrill, any advice on any of that?
Yeah, I wanted to add, I read a really cool article not that long ago about different ways to actually tie shoes. So, you know, we do the same thing all the time. And there's other ways to lace the shoes that keep the shoes on, but there's less pressure across the top of the foot and across the same tendons that are already irritated. So it was pretty interesting. I think it was in Runner's World. I found it online, of course, because my foot hurt. So, but it was very interesting because, you know, you don't think about doing that, but you can lace shoes completely differently than the traditional way, and it takes a lot of pressure off.
That's excellent advice. So Jessica just chimed in that a CVS shoe insert helped neutralize her relative leg length discrepancy. And I would say if it's under, as Keith said, 1/4 of an inch, you typically don't need much, and it can be pretty much ignored, but sometimes it does cause pain. So I think one of the overall questions is, what can we do to prevent, you know, injury, right? And we've chimed in on a little bit, and obviously core strength and flexibility, but we haven't really touched base about the upper extremity and the elbow injuries and the overuse at the wrist of the elbow. Does anyone want to chime in on what they've seen with rowing injuries at the upper extremity?
I mean, I think, again, most of us row with tennis elbow, a lateral or medial epicondylitis. And, you know, you and I know the anatomy that these are it's, you know, a lot of it is repetitive activity at the wrist, but the wrist extensor, it attaches on the outside of the elbow as you're with your hand facing the ceiling, and the wrist flexor attaches on the inside. I think some of that is easily, and you know, the attachment is a short, stubby little tendon. It's not what we think is a true tendon. And usually there's not acute inflammation. Usually it's, again, micro tears of the tendon that induce scar tissue. So people hate when I do this, but when they have it, I go right with my own fingers for the maximal source of pain. They usually, start running away or getting aggressive. But it's really having people do their own manual work to really do self-massage, go right where the pain is maximal on the bone, and really just get your fingers in there and massage it to try to break up the scar tissue. Because the scar tissue then causes maybe shortening, but not optimal contraction of the muscular groups when you're feathering. So I don't know that lateral is more common than medial, but it seems that it is.
I would also suggest if anyone has a Theragun or access to one of those massage guns could be really helpful. Just kind of get in there with that too. And I swear by diclofenac or Voltaren gel, some topical ointments. Chris is giving a thumbs up. It's now at Costco. It's over the counter.
Yeah, my fellows make fun of me because at the end of the patient presentation, I go, "What do you want to do?" Physical therapy and diclofenac gel. I love it. I know it's not a topic, but since it's been over the counter, I've had a lot more patients try it, and I've actually been surprised of how well it's worked for any product or any part of the body. I kind of relate it to French red hot sauce. Just put it anywhere. And I think of it as low risk, high rewards, rather than putting people on pills that, especially as you get older, more trouble for stomach issues, kidney issues. And a lot of my athletes, they don't want to be on pills all the time. And I've actually got a lot of buy-in from my student athletes of, like, hey, I don't want to take more pills. I want to try something to still kind of have some of that anti-inflammatory and pain relief properties so they can get better. And, if you can get pain down, that'll, decrease that muscle inhibition. So that's where sometimes I'll get sciencey with them of like, why do we actually want to get the pain better and not just work through the pain is, you can regain some of that muscle activation if you can actually get it to calm down. But I recommend it to everyone.
For those of you who can't use these types of medication, my favorite is it's a Chinese herbal patch called Vita Ease, and you usually VITA-EASE. You can find it usually in the city. You can find it in the Asian supermarkets or pharmacies on Washington Avenue. Smells good. I don't know what's in it, but it usually, and you can leave them on for 4 to 6 hours. You don't want to leave them on forever. I'm also a great believer in developing a relationship with a massage therapist, somebody that really that you see, that gets to know your body over time, and that can sort of put you back to baseline after particularly a week or periods of aggressive rowing. Spend the money. I think in the Philly market right now, the market price, usually cash, is somewhere between $100 and $200 an hour. But you don't need to go every week.
Yeah, no, I think massage therapy is great. And again, the Theragun is something you can do in your house too, to kind of mimic, definitely not the same as being with a massage therapist. And I will say Arnica is another great anti-inflammatory gel if you can't use an NSAID on your body for any reason. But something that you can do, not having to do oral, is definitely wonderful. My mom mentioned, and I think we're running out of time, so I'm going to just highlight the major injuries you see in youth rowers compared with athletes, older athletes, I think is what she's saying, and how do you manage that? I will say, I think the biggest management and expectation is how do you avoid the frustration when you say you can't row? And how do you take that out? And I think that the injuries are very similar in the adults and the youth, except there may be not as much disc degeneration and there may be not as much wear and tear, but it's still there. And you'd be surprised with when you get an MRI of a 16-year-old how much disc degeneration there already is in a 16-year-old lumbar spine. But I think that it's really, they're still growing and they're still developing. And so keeping in mind, if you're taking care of high school athletes, there are 16-year-olds that look like they're 12 and there's 16-year-olds that look like they're 20. And so making sure that you're treating them all who they are and based on their development and not just treating them as an adult just because they're 16. And so I think, having someone, you have a massage therapist, you have a physical therapist, you have someone that you can go to, seeing a physician that's trained and understands why rowers are getting these injuries. I start talking about, form in the boat, and people are often like, you actually know what we're talking about? You know this form, and you know what sweep means and what skull means. And so if you go to a physician that doesn't know what they're talking about, and they just know back pain, but they don't know why they're getting the back pain, you're not going to necessarily get the answers that you want. So Jen, I think we're running out of time at 7:57. I want to make sure that if there's anything else to talk about during the story hour, turn it over to you.
Thank you so much. I did see that Jim Dietz wanted to chime in. Jim, did you want to add to something that was talked about?
Yeah, I think all of the physicians here touched on it tonight, and the big thing is posture. All right, and that as a preventative measure to keep these athletes healthy. I mean, posture is everything, and that comes down to coaching. Better education of the coaches to focus on this. I would walk in to erg rooms and see what coaches were allowing people to do, and I'd want to scream. I mean, this is destroying our people, and it really has to be addressed that the coaches pay attention to this. The other topic that I wanted to touch on, and Rick Stellick chimed in on it a little bit earlier, is sculling. In Europe, kids aren't allowed to row sweep until they're 18 years of age. All right. I was just in Croatia in Srebrenic at the Club Krka, right? All the kids are sculling. Not only are they just sculling, but they're sculling with Macon blades, right? With not these big hatchet blades that are getting, hatchet blades came into vogue and there were more rib injuries than you knew what to do with. That's just abusing athletes. It's not necessary. Teach people how to row properly with a Macon blade. There'll be fewer injuries, but it has to start at that younger level. And the coaches really have to focus on that technique. If you're sitting up properly in a boat, Naomi, you're doing so much core work over that hour and a half that you're in the boat that, and if the coach is paying attention to that, you're going to get off the water and say, boy, do I feel it, and that's a good feeling, so that's just my 2 cents as to, in our country, we have to address more coaching education where these coaches really understand proper body posture, how to breathe, what their athletes are supposed to look like in a boat. And, my motto is friends don't let friends row sweep, keep everybody in sculling boats.
I would also throw it on the parents really quickly as saying, and all of you with how you're holding your phone and how you're holding your technology, is that it's not just on the river how your posture is, but it's how you are in your daily life. Because what carries over from, you just get so stuck with this forward rounded shoulder position that it can really affect everything.
I think that it is super great advice, both Jim and Naomi. I think that, across the board in all aspects of our life, we're constantly, rushing to the next thing and not taking that extra time that we need. So education, once again, is probably one of the best ways to combat a lot of these injuries from happening. So any final questions anybody would like to chime in with? All right. Hearing none, it is 8 o'clock, and we really appreciate you spending the hour with us tonight. A sincere thank you to Naomi and Chris and Keith and Merrill for their time and sharing their knowledge and experience with us. It was very comprehensive, and we appreciate you sharing with us. From bone health workups, which we don't talk enough about, nutrition, where to get that good gel, and posture. There's things that we can do to help our own cause here. So I appreciate you joining us tonight. Chris, we hope we can get you on the water at some point in the future. I'd also like to express my appreciation for our Committee 50 members who are mostly on tonight: Alan Robinson, Jim Dietz, Ellen Carver, Christopher Blackwell, Rick Stellick, Dottie Brown, and Chris Doyle. When I reached out to them 2 years ago now, this was merely an idea to have these story hours, and their energy and enthusiasm has created a vision for sharing stories and connecting this community and really preserving our history for generations to come and to use for their betterment. So you can see recordings of all our past story hours on the HOS, our YouTube page. You can access it through our website, www.hsor.org. And just a few reminders, I'd be remiss not to let you know that we have another story hour next week, Thursday, September 29th, and this one will be focused on one of our rowing giants, Jim Dietz. So I will be sending the wrap up of this story hour as well as the information for registering for the next one in the next day or two. Registration for the 52nd HOSR to be held on October 29th and 30th is open. Deadline is October, I want to say 9th. And volunteers are always needed and appreciated. We'll work around your rowing schedule that weekend, or just come have fun with a great group of people. So if you'd like to volunteer, reach out to me, or you can go to the website's volunteer page and sign up there. So wishing you all a very good night, great week, and be safe out there and stay healthy.